So my talk today will be discussing using any body to compare healthy and osteoarthritic knee kinematics and kinetics. And just a little bit about myself. I'm a physiotherapist by background, and I started my PhD a couple of years ago looking into pre- and post-operative knee arthroplasty function. And some of the tools that I'm using are motion analysis, which includes the Vicons and force plate EMG, obviously using the Anybody musculoskeletal modelling system, and I also incorporate a number of clinical tests such as questionnaires, range of motions, ultrasound imaging, in order to get a sort of evaluation of patient function. The main use of me using Anybody is the ability for it to predict knee kinematics and kinetics during activities of daily living. So we normally make our patients do a number of different activities and then try and use Anybody to predict the outputs. And during this webcast, I'll be presenting my early findings of preoperative patients. So this is sort of end-stage knee osteoarthritis patients that have come in normally around about 4 weeks before they had a knee arthroplasty. And today I'll compare the findings to those of a healthy age-matched cohort that I used as a control group. Just briefly touching on osteoarthritis, for those who don't already know, it's the degeneration of the cartilage around the joint, and this degeneration often changes the mechanical axis of the knee. It normally causes a lot of pain with the patient, and pain is one of the main reasons for them to go in to have a knee arthroplasty. And it also causes a lot of weakness on the affected side. Normally you see quite a lot of adaptation of activities of daily living, so patients normally adapt the way they move in order to protect the damaged joint. And often due to this you see a loss of function, so patients lose the ability to perform activities of daily living the way they normally would, and their function is normally below that of the healthy age-matched population. Just to highlight the problem that osteoarthritis causes, especially within the UK, it's estimated that osteoarthritis causes joint pain in 8.5 million people in the UK, and about 20% of adults aged 45 to 64 have osteoarthritic pain in the knee, and about 35% of women over 75 have osteoarthritic pain in the knee. And in terms of disability, around about 25% of adults of 50 years of age or more report disability from severe knee pain. And in 1999 to 2000, 36 million working days were lost due to osteoarthritis, causing the economy £3.2 billion worth of loss of production. And also to add to this, around about 20,000 knee replacements are performed each year in England and Wales, obviously causing a great deal of expense to the national health system. So in order for me to assess knee kinematics and kinetics during activities of daily living in our osteoarthritis patients, we selected 20 healthy individuals from the community, which were age and sex matched to those of the osteoarthritis patients. We gathered 20 preoperative OA patients from Southampton General Hospital that were taken from the knee arthroplastic surgical list, and each participant was in the lab for around 2 hours. Obviously, informed consent and ethics was sought before the testing started. In terms of our data collection, at Southampton here we have a 12-camera Vicon system, along with 2 tests of force plates and 16 channels of zero-wire EMG. And the 2 activities I'm going to highlight today are gait and sit-stand, but we also assess things like step, descent and lunge. It is of note at this stage of the data collection, although we have very nice facilities at Southampton, you have to acknowledge the possibility the noise from the bicorn and both force plates, and also the soft tissue artifact that you find with most externally placed motion analysis, and especially areas around about the thigh and the shank have been shown to produce quite high levels of soft tissue artifact, up to the region of about 20 millimeters. In addition to these sources of error, you also have anatomical landmark definition error. With most marker sets, you place the markers over bony landmarks. However, even as a qualified physiotherapist, there is quite a large room for error during this process due to the fact that some of the landmarks are much larger than the markers that you're placing on. So there is room for error there. And this is the tricky bit. So after we've collected the data from the motion capture system, we're then going to try and convert those marker positions and sort of patient anthropometrics into this scaled anybody model. Now you can take a number of different measurements, such as pelvis width, thigh length, shank length, foot length, in order to try and scale the model as accurately as possible. And then you also have to estimate the marker positions relative to the model to predict what you have collected within the lab. And certainly there are a definite room for error in terms of estimation of these marker positions on the model relative to the marker positions captured in the lab, because the graphical representation of the sort of scale version in anybody doesn't necessarily correspond 100% to that of taken in the lab. So again, you have to be sort of fairly subjective in this process of converting the lab-based data into the anybody model. However, there are some nice features in anybody which make life a lot easier, and we'll brush on those in a bit. Now, in terms of when you've had a scaled model set up, you then look to add a muscle model system. And for this, the anybody uses the Klein Horseman muscle data set of over sort of 300 muscles in the lower body in the TLEM model, which is a very nice application. However, a lot of these muscle forces and sort of the cross-sectional area, the tendon length, the pronation angle, is all taken from this one sort of generic anthropometric set. So again, there's a room for some error in the transfer across the sort of the rest of the population. However, here at Southampton, we're trying to use some techniques in order to try and scale our muscle predictions more accurately. Now, for our osteoarthritis patients, we know that there is a potential for muscular imbalance. So often with an osteoarthritic knee, you get atrophy, which means muscle weakness in the affected side. And ultrasound imaging, which is basically the use of sort of high-frequency ultrasound waves, gives us the opportunity to measure those muscles both on the affected side and on the unaffected side. And we can see from muscles such as rectus femoris and the quadriceps that actually before patients go under for a TKR, total knee arthroplasty, they have around about 25% muscle atrophy. And for those going under a unilateral knee replacement, we found around about 15.5% atrophy. So quite a lot of muscle wasting within the knee. And if we look at the other vasti muscles, such as vastus medialis oblique and vastus lateralis, again, we're seeing an atrophy. And these atrophies are at about 9.1 and 2%. So not as much muscle atrophy, but again, a significant amount. And not only can we look at the muscle in its relaxed state in terms of muscle size, we can also have a look at the muscle when it's contracted. And we found that there was 5.5% difference in contractibility. So that's the ability for the muscle to contract inside for both the total knee replacement patients and the uni knee replacement patients. So we're seeing a loss of muscle size and contractibility. And for that, we can put those features within our model, so sort of scale the percentage of physiological cross-sectional area of these particular muscles to suit that for each patient. And when we have our scaled model that's got the sort of patient-specific anthropometrics, the markers, the muscle model, we can then start to look at modeling the actual movements. And now in anybody, the application is a very easy process in which you can take the C3D data from the Vicon system, plug it straight into the model with your preset sort of patient-specific model. And in order to find our optimized kinematics, we can use Michael Skipper Anderson's algorithm in order to optimize the kinematics across the time frame. And as I'm sure you're aware, it sort of minimizes the estimated measured marker trajectory error across each time frame, subject to the harmonic constraints. And those constraints are things like the hinge joint at the knee, the 3 degrees of freedom at the hip, the 2 degrees of freedom at the ankle. And Michael Skipper's basically found that through his optimization, you get a smoothing of the position vectors, which in turn smooths velocities, and in turn has quite a large effect on smoothing the accelerations of each segment, which in turn will give much better output when we come to run inverse dynamics. And in terms of the marker sets that we've used, we trialed a modified Helen-Hayes marker set, which is on the left. And in addition to the standard Helen-Hayes marker set, we've added a fifth metatarsal and navicular marker just to control the inversion eversion of the foot, and that tends to give us quite nice results. It is of note that the markers for most amount of FTA, such as thigh and shank, you can actually visibly see the markers moving away from the predicted marker sets, which is what you'd expect. We've also trialed using technical marker sets, so this is a marker set of 4 markers on the thigh and on the shank that's sort of rigidly linked. And again, we're finding fairly good results for these technical marker sets, although we sort of have stuck to the standard Helen-Hayes marker set for most of our data collection. And now we come to run our inverse dynamics, which I'm sure you're all familiar with, where we're inputting our optimized kinematics. We then run the full calibration on the muscles. And now in anybody, you have an automated script for adding force-plate data, so that's directly taken from C3D and added to the inverse dynamic model. And then we're currently using a polynomial sort of power of 3 muscle recruitment solver in order to find the indeterminacy, so that the muscles are equating the moments required to resolve each moment about the joint that's been calculated. And from these models, we then output our knee kinematics and kinetics into a MATLAB script, which can then get post-processed. Before we go on to comparing the healthy and osteoarthritic knee patients, first I'll run through a little bit of the verification process that we go through. And this is verifying the kinematics. We found a paper from Moran et al. That looked at a similar age cohort of healthy individuals, and we can see our kinematics follow the same line as what they've discovered. And also our standard deviation is very similar to that was previously reported in the literature. If we continue to look at the verification, this is axial loading at the knee joint. We have the force in body weight down the left, and this is percentage of the gait cycle. And we can see that we peak at around about 3 times body weight for axial loading. When we take data from the literature, such as the ISO loading for wear simulation, we find that it's a very similar pattern in loading, albeit a slightly different time phase for the percentage of stance during the gait. So their stance ends at around about 55%, whereas ours lasts around about 63%. But the magnitudes of loading are very similar. However, if we take data from an in vivo data set, this is a paper by Heinen et al. Using a telemetrized knee arthroplasty, which basically measures the forces in vivo, so actually within the knee while someone's walking. They actually found that there's around about 2 times body weight going through the knee. So slightly less, around about 1 body weight less than what our antibody models are predicting. But again, this data, this green line, is from the healthy cohort of individuals. So there could be a discrepancy in terms of the knee arthroplasty patients versus the healthies. And it's also of note that these data from the Heinlein paper is fairly restricted in numbers still, so they've only seen a few patients. And I think if they saw a few more, we might see some slightly higher loading at the knee. And if we look at other forces within the knee, this is eye-knee torque. Our healthy data is in the green, the standard deviation and the red dots. The ISO standard is in the blue, and the ortho low is in the black. And again, we see very similar magnitudes of eye torque rotation at the knee compared to the current literature base. So again, sort of verifying the outputs that we've found. And if we look at other papers that have used inverse dynamics to predict knee loading, again, we can see there's a general trend of around about 3 to 3.5 times body weight in actual loading, which our model is also predicting. The PA constraint reaction is around about half times body weight, and ours is a little higher than that for our healthy control group. But again, these patients are a mixture of arthroplasty, young cohorts, so there's lots of different patients within that. Our lateral medial constraint reaction is very similar to that found by Costigan a few years ago. And as we said before, our IE torque is very similar to that found in the previous evidence base. So in terms of comparing anybody to the previous inverse dynamic predictive models, the data looks very good in comparison. In order to further sort of verify the outputs we're getting, and this is a verification of the muscle activation prediction by anybody, we can compare our data to the EMG that we collect. So on the top we have a time trace of the EMG, and when you see the spike in activity, that's when you know that the muscle is active. And on the bottom we have the PMET, or metabolic output of the antibody model. And you often see these sort of curves and straight lines in antibody predicting the sort of metabolic output for each muscle. Now, the way in which we try and sort of normalize this data to compare against each other is we provide a cutoff frequency when we determine a muscle to either be active or inactive. So when the voltage of the EMG reaches a certain magnitude, we call it active, and when the metabolic output reaches a certain magnitude, we define that as active. And you can see with the green being the metabolic output from anybody and the red being the EMG, that we have fairly good agreement between the EMG and the antibody outputs. Although you can see areas of disagreement that obviously don't quite correspond between EMG and antibody. However, with the assumptions that the recruitment solver makes, this is a fairly good agreement in our opinion. So if we now finally come on to comparing our healthy to our osteoarthritic knee patients, this is a trace of the knee flexion angle with a healthy mean in green and standard deviation in red. And then the blue trace is the mean of the osteoarthritic patients. And you can see a general trend is that the patients who have osteoarthritis have a decreased extension knee angle during stance phase and a decreased flexion angle during spring phase. And this has previously been reported in the literature, and this sort of suits a general pattern. But it is of note that there are quite high standard deviations for both the healthies and the osteoarthritic knee kinematics. And this in turn does have quite a large effect on the kinetics. So this is a table of all the kinetics, the axial loading, AP constraint, medial lateral constraint, valgus varus moment, IE moment, and flexion moment. And one of the main findings is that we're finding an increased loading on the unaffected side, so a higher axial loading. We're also finding higher moments about the osteoarthritic patients in terms of valgus varus moment and IE torque moment on both the affected and unaffected side. And we're also finding a decrease in flexion moment, and this sort of goes towards the trend of saying that the osteoarthritic patients are walking more slowly than that of the healthy individuals. However, you can see with these bracket lines the standard deviation, and it's certainly of note that the standard deviations for the osteoarthritic group were very high, much higher than that of the healthy group. And that's mainly due to the variation in sort of the gait pattern that you see in osteoarthritic patients. And it certainly makes things statistically harder to find significant results, and actually none of the results are significantly different. However, you do see a general trend in increased moments in VV and IE and decreased flexion moment. However, gait is an activity that most patients can perform fairly comfortably. Now, when we put the patients into an activity that's slightly more strenuous, such as sit to stand, we actually see much larger differences. And in the video here, the blue lines are representing the force plate data. And actually, in some of our osteoarthritic patients, you can actually see 2, 3, perhaps even 4 times the weight going through the unaffected side, the side without osteoarthritis. And this has a potential for the early wear of the healthy side. And because the body is trying to protect this damaged joint, often the patients are performing this subconsciously. In their opinion, they think they're putting an even amount of weight on both sides. However, we can see from the force plate data that actually there's a large asymmetry in the way they load their 2 limbs during sit to stand. And in terms of the forces going through the knee, there's a much larger difference from that we saw in gait. So if we have a look at the unaffected side, we're seeing quite large axial force and AP force in the green and blue respectively on the unaffected side as compared to that on the affected limb. And we're almost seeing a double in the knee forces going through the unaffected side during a stand sit. And again, with the sit to stand, quite high AP and axial loading on the unaffected side, and again, around about 2/3 of that on the affected limb. So there's a large discrepancy between loading between the 2 joints. And if we have a look at the muscle inputs, this is from Vastus Lateralis, and this is the activity, so in terms of percentage of maximum voluntary contraction, we actually see that the unaffected side is having to work twice as hard as the affected osteoarthritic side. And this in turn can lead to early fatigue and again, some early sort of wear and strain on the unaffected side. And these sort of low MVCs that we see on the osteoarthritic limb correspond to that we saw for our ultrasound, where we found that the muscle was atrophied and lost the ability to contract. And actually, anybody is showing that the model is showing this sort of decrease in activity, which corresponds to our sort of previous ultrasound imaging process. There's always room for improvement with all of these studies, and certainly it has been shown that the inverse dynamics is quite dependent on accurate data collection and the sort of process of converting the motion capture to the inverse dynamic model. However, obviously with the continued improvement and obviously Michael Skipper Anderson's algorithm, we're making great gains in this area. Things such as the simplification of segments such as the foot can sometimes cause quite high reactions at the knee, where you get a large cartilage involvement due to a large moment arm around the ankle. We know currently joints are idealized by constraints, and ideally we'd like a 6 degree of freedom knee model, because we know the knee can translate and rotate about all the planes. However, in terms of keeping the efficiency of the modelling and keeping the robustness, currently the hinge joint is the best option. And we obviously know that the generic scaling process of the model perhaps does not represent the varying physical properties of all the populations. And we also know that there are soft tissues ignored, and currently there is no co-contraction recruitment solver, and co-contractions are fairly prevalent in osteoarthritic knee patients. However, I believe in some of the latest releases that they are planning on addressing the application of co-contractions into the modelling process. And finally, just to sort of discuss what I found, the predicted loading about the knee is comparable to the current literature data set. And we found that electromyography has a fairly good correlation with the metabolic output of the antibody bottoms. We found that there was altered loading in the osteoarthritic patients for both gait and sit-to-stand, although we did find a very high variance in all the loading patterns, especially in the osteoarthritic group. It seems that the harder the activity, the larger the asymmetry we find in joint loading, and this has clinical implications that the side that's not affected by the osteoarthritis has the potential to have early wear and degeneration. And actually it's been shown in a number of studies that patients who have sort of these adaptations through their osteoarthritis actually retain them after they've had a knee replacement. So if someone is having twice the loading going through their unaffected knee for an extended period of time, maybe 2 or 3 years, then there's an obvious indication that could wear the unaffected side prematurely. For my future work, we definitely want to be working towards a 6 degree of freedom knee model, where we can represent the anterior-posterior translation, i.e. rotation about the knee. However, as Michael Skipper has shown in one of his recent papers, even with the best optimization methods such as his own, we still aren't getting particularly accurate results from external motion capture. And perhaps we'll have to look to other modalities such as fluoroscopy to get a slightly more accurate idea of how the knee is translating and rotating in order to input that information into a muscle splitting model. Another thing that I want to be working on personally is a lot of the patients we saw had quite a large valgus or varus knee angle, and this is normally due to specific wear on a compartment in the knee. So this person in particular had medial knee osteoarthritis causing a varus knee angle, and I want to try and incorporate that into the Anybody model in order to best reflect his sort of particular knee posture. I'm also presenting at a couple of conferences in Brunel and in Edinburgh, and that'll be on the continued work that I've been doing, and it'll brush on some more of the EMG comparison, and also some more on the implications of the sort of asymmetry and loading about the knee joint in the patient's routine. I'd like to acknowledge my supervisors, Professors Taylor, Stokes and Barrett, along with the sources of funding from DePuy and the EPSRC, and along with the very much appreciated continued support from anybody. And I'd like to open the session up for some questions.